Now, on to today's business. So I'll turn it over. Kathy Donison is our Chief of the Health Plan Administration Division, and she's here to moderate a discussion about the future of high-deductible health plans. We know that about 25% of covered employees select these plans during open enrollment. I'm sorry, David, yes?
There we go. I just had a question before we get started. I'm just wondering how we ended up with this on our agenda. I've been getting a lot of communication this week that kind of on the heels of changes to health plans and everything that were in many cases viewed as having some elements of cost shifts to employees, that taking up high deductible plans, which is an absolute non-starter for virtually all of our member organizations, certainly all the organized bargaining units, seems like to them quite an affront. And I'm just wondering, the timing and how we came to this before we get started.
Thank you for the question, Mr. Miller. This came out of, and I'm not certain, or I can't recall which month it was, but there was committee direction to bring the analysis on high deductible plans to the offsite. And so that came from the committee via direction.
So today, just continuing on, we're going to learn about the pros and cons of these plans and how plan design impacts member utilization of covered services and their associated costs, among other things. Dr. Donison and her team have assembled a panel of presenters representing all aspects of the healthcare landscape, and I'll let Dr. Donison make the introductions. So welcome, Kathy, and please begin whenever you're ready.
Good morning, board, members of the committee, members of the public, and other stakeholders present today. We have a distinguished panel that I would like to introduce that are going to discuss different aspects of high deductible plans. Could I have the next slide, please? Oh, I guess I could. There. We brought together this distinguished panel, Dr. Niraj Sood, Professor and Vice Dean of the Sol Price School of Public Policy and the USC Schaefer Center from the University of Southern California, who has done extensive work in the academic world on looking at the pros and cons of high deductible plans. I'm pleased to have two senior vice presidents representing human resources procurement activities from the private sector, Samantha Dubridge, Vice President of Global Benefits from Hewlett-Packard, and Jerry Burrell from McKesson's Benefits Program. And they will also talk about their experience, not just with consumer-driven plans, but also with standard traditional plans like Kaiser, other self-funded programs that they have. So I think what they're going to bring is a good perspective in terms of directions they've been, which has been similar to CalPERS journey and directions they're going. And then Dina Mendelsohn, who's a senior attorney with Consumers Union, will talk about the consumer's perspective. So I'm very pleased that we have a distinguished panel to educate all of us on where we are in the current landscape with high deductible plans. Let's see. There we go. There we are. So I want to talk a little bit about the CalPERS journey in terms of our plans. We have 9 health maintenance organizations, and some are regional, some are statewide, and some are in between. But we have very good coverage in terms of our commercial HMO plans. We have Anthem, Blue Shield, we have HealthNet, Saluti Moss, and SmartCare. We have Kaiser Permanente, Sharp, United, and Western Health Advantage. But we also have 3 self-funded preferred provider organization plans, one which has a new value-based insurance design through PERS Select, and then our worldwide plans of PERS Choice and PERS Care. We also have 3 association plans, and we have quite a wide array of offerings between our plans. High deductible plans have many viewpoints And what we want to look at today is the evidence around high deductible plans. CalPERS periodically has done education programs. We did in 2009. We did in 2014, and now here we are again to look and see where the landscape has been and where it's going. But I want to remind that a couple of things about our program. One is that we offer active employee health benefits. We offer early retiree health benefits. We offer Medicare benefits. We represent about 1,200 contracting agencies as employers. Our own California Human Resources Department is the state of California employee. And then we have other stakeholders like our health plans who advise us on benefit designs, and other stakeholders as well. So we represent a diverse set of viewpoints and a diverse set of interests, and that's why I've brought this panel here today, to try to discuss and offer for you where we are with high deductible plans, as well as other plan designs that we've used, like reference pricing and value-based insurance design. So with that, I am going to turn it over to Dr. Sood from the University of Southern California, who will talk about his research.
Thank you, Kathy. So just from the introduction, it seems it's going to be a fun discussion afterwards. So I'm looking forward to that. My goal is I'm a professor of public policy at USC. I've done a lot of research on high deductible health plans over the past decade. This research has been funded by NIH, California Healthcare Foundation, and some other foundations. All of this research is peer-reviewed and has been published in leading health policy journals or medical journals. And this is not just my research. I've had collaborators at Rand, Harvard, CMU, Minnesota, and other universities. So just to kind of get started on what are high deductible health plans, the way we defined high deductible health plans in our studies was that they at least had a deductible of $1,250 for individual coverage and $2,500 for family coverage. These plans were often associated with tax-free health savings accounts, and when you combine a high deductible with a tax-free health savings account, these plans are often called consumer-directed health plans. So if you kind of just think about the economics of it, since the plans have a high deductible, they're going to have lower premiums. The benefit generosity is lower. But it also means that consumers will be paying more out of pocket when they actually go to receive health care. So if you just think about these two incentives, these plans are going to be attractive to people who care about the low premiums but are healthy enough that they don't worry about going to the doctor. So that basically says that these plans are going to be more attractive for healthy consumers who want the premium savings but who are not worried about the deductible or spending more out of pocket at the time when they get health care. So these plans have been very popular. So in 2006, about 4% of employees had high deductible health plans. According to 2016 data, about 29% of employees have high deductible health plans. So that's a fold growth in enrollment in these plans. If you look at the health insurance exchanges, then by some accounts, 80 to 90% of the people on health insurance exchanges are in high deductible health plans. So these plans are in some sense an important part of health benefits or health insurance in the US. So what I'm going to do is, kind of like all economists, I'm two-handed. So I'm going to present on the one hand some pros of these health plans, and on the other hand some cons of these health plans. So in theory, these health plans were sold based on two promises. One, that they will reduce healthcare costs, and second, they will make people or consumers smarter consumers, or they will make consumers make more value-based decisions. So people will not only reduce costs, but they will reduce costs in smart ways. The con is that, as was kind of foreshadowed by the initial discussion, that maybe this is just cost shifting, that all you're doing is taking the burden away from employers and putting it to employees. And this higher financial burden will lead some employees or some consumers to basically forego necessary health care. And this will, in some sense, hurt consumers in the long run, because if you don't go see your doctor for managing your chronic conditions, you're going to end up in the hospital 5 years down the line. So that's what the debate about these plans is. The other thing is that they also might make the health benefits less stable. So what will happen is, as I said earlier, that if all the healthy people move into high deductible health plans, then the traditional plans or the PPOs, which offer generous coverage, are stuck with the sicker people. Their premiums rise, and when their premiums rise, more healthy people switch from PPOs to high deductible health plans till the point of time where the PPOs might become unstable. So that's another empirical question, that the extent to which healthy people actually enroll in these plans, and what impact does this have on premiums for traditional health plans. So what we find is, this is based on data from not just one employer, but from about 54 large employers, that these plans indeed reduce healthcare costs. So this is system-wide costs, not just the cost for the employer or the employee, but the total system-wide cost. So in the first year, the savings were about 22%. So if you enroll in a high deductible health plan, the estimate said that you basically had a 22% reduction in your costs. In the second year, the cost reduction was about 13%. And in the third year, we followed people up to 3 years, the cost reduction was about 8.5%. And these savings were driven primarily by reductions in outpatient care and drug spending. And we saw little or no effect of these plans or enrollment in these plans on ER or inpatient spending. So you might say that this is good news, that if people were foregoing necessary care, we should have expected to see an increase in ER or inpatient spending, and we don't see that in the first 3 years. But some people say, that's great, but 3 years is not enough time to really see people's health deteriorate and them ending up in the ER or in a hospital. So maybe this is not still conclusive. We also looked at data on who are people enrolling in these high deductible plans. And what we found is that people who enroll in high deductible plans, they were healthier. So their costs in the year prior to enrollment were already 25% lower. So what this means is that now if 20% of these people move from a PPO to a high deductible plan, the PPO premiums are going to rise by about 5%. So the implication is, when you're going to offer a high deductible health plan with other generous plans, you should expect to see about, depends on how many people enroll in the high deductible plan, but about a 5% increase in premiums for the more generous plans. Employers can mitigate some of this by making the high deductible plan in some sense more generous. One way to make it more generous is for the employer to contribute to a health savings account. So basically what we find is that the degree of selection can be reduced through some employer strategies. So now kind of to the cost shifting part. So what we did is we said, let's look at how these plans affect out-of-pocket costs. And we defined that if you're spending more than 3% of your income on out-of-pocket costs for healthcare, then we define that then you have an excessive financial burden of out-of-pocket costs. So this is kind of the standard used in the literature. And what these graphs show is that when people enroll in a high deductible plan, their probability of having excessive financial burden of out-of-pocket costs does increase. These trends are parallel prior to enrollment, but as soon as you enroll, you can see the blue line kind of going up above the orange line. And these effects are much bigger among the lower income population, which in some sense makes sense, that if you're lower income, it's more easier to hit that, a higher out-of-pocket cost is going to be a bigger fraction of your income. So just to look at some numbers, if you're in a traditional plan and low income, you have about a 1 in 3 chance of having excessive burden of out-of-pocket costs. But if you're in a high deductible plan, then you have about a 52% chance, or the majority chance of having excessive financial burden. And the picture is similar when you look at those with chronic conditions. So if you're in a traditional plan, your probability of excessive burden if you have chronic conditions is about 22%, but if you're in a high deductible plan, this goes up to about 37%. So there's clear evidence that people will face more financial burden when they are in these health plans. So now let's kind of go to the other promise of these plans, that are they making people smarter? Are we saving costs in smart ways? So if you think about cost is basically price times quantity. So quantity is how often I go to the doctor, and price is, do I go to the most expensive doctor in Beverly Hills, or do I price shop and go to someone in Culver City? So we've kind of looked at quantity choices in terms of, does this make people smarter by reducing the use of low-value care? So if I have back pain, it's the first time I have back pain, I should not be getting an MRI for that. So do people forego MRIs for back pain when they're in a high deductible plan? Or do they increase use of high-value services? So a lot of these plans carved out preventive care. They said these are high value and we're going to carve them out. So the question is, do people get their cancer screenings on time when they're in high deductible health plans or not? And similarly, we looked at price shopping for care. Do you go to the more expensive doctors versus the cheaper doctors? And basically what we find is when we looked at preventive care, we find that there's no effect of enrolling in high deductible plans on the use of preventive care. And this is despite the fact that preventive care was free. So the out-of-pocket cost for preventive care was zero in these high deductible health plans. And interestingly, what we find is, so if there's open enrollment in October, so people enroll in a high deductible health plan in October, and then in December, they're getting their colonoscopy or their mammogram, even though if they'd got the same procedure in January, it would have been free. But why are they doing this? Because no one reads the fine print of their health plan. So they just think they're in a high deductible health plan. This is going to be expensive in the future. Oh, it's December, let me get my cancer screenings. So they pay more out of pocket when actually if they'd got this in January, it would have been free for them. So we kind of see this spike up in use of preventive care in the last quarter after enrollment in high deductible health plans. So the second thing we looked at is, what about drugs for chronic illness? So this is statins, anti-diabetic drugs, or antihypertensives. So these are kind of interesting because if you have a chronic condition, like I take my statins every day, I know what they are. I know the difference between a branded statin and a generic statin. So there is an easy way to save money if I switch to a generic statin. And I've been doing this for a while. Like this is a known entity or quantity for me. I've been taking my statins for a couple of years. So the question is, if someone like me enrolls in a high deductible plan, how does it change my use of statins or drugs for other chronic conditions? And what we find is, so if you can think about that, again, there are 3 responses. So the first response is, I should switch to a generic statin. That would be a smart way to save money if I'm in a high deductible health plan. The second thing I should do is, on December 31st, I should get a 90-day supply of statins. Because I know on January 1, they're going to be more expensive. At least let me cover the first 90 days on my traditional plan with more generous coverage. And the third thing I can do is, I can just stop taking my statins after a while because they're more expensive. And what we find is that 90%, so we find evidence of all these 3 behaviors, but we find is 90% of the savings come from discontinuation. So basically people stop taking their statins, stop taking their anti-diabetic drugs, so there's a drop in utilization of these drugs. And now this points to, if you combine this with the clinical literature, this points to adverse health effects down the line. So if I stop taking my statins, maybe 10 years down the line, I will have a higher risk of stroke or a higher risk of heart attacks and so on. So we also looked at, so I'm sure a lot of you are familiar with Choosing Wisely campaign. So this is basically professional society, so radiologists, pediatricians, et cetera. Every professional society of doctors was asked to come up with 5 procedures which they thought were low value, which were basically costly but provided little or no health benefit. So we looked at the use of 26 such low value procedures, and basically we found is that when you enroll in a high deductible health plan, there is no change in use of low value care. So again, you're not making people smarter. If people were becoming smarter when they enrolled in high deductible health plans, they would stop using low value care, stop getting the MRI for their back pain and so on. And interestingly, when I was presenting this to another group, one of the people who was a consumer advocate said, from a consumer's perspective, there is no low value care, right? If I have back pain, I need my MRI, right? I'm not a doctor, so I don't know, I cannot distinguish between low value care and high value care. I just want to know what's causing my back pain. And somehow just getting an MRI makes me feel better knowing, what is causing it. So this is in some sense low value defined from a clinical or a medical perspective, but not from a consumer perspective. So the last question we've kind of looked at is, do these lead to smarter price choices? So what we did is we did a nationally representative survey. Some people were in high deductible health plans, and some of these people were in traditional health plans. So one way you can kind of shop around for care is, so we asked that the last time you used medical care, did you think about going to some other doctor or some other provider? And basically we got about 1 in 10 people said, yes, we thought about going somewhere else. But there's no difference whether you're in a high deductible health plan or not. So about 1 in 10 Americans think about shopping for another doctor or another imaging facility or lab facility. Similarly, we said okay, did you compare prices? If you thought about some other people, did you compare prices? And here it was basically about 3% of the population said we compared prices. But again, there's no difference between high deductible health plans versus traditional plans. So again, even though the premise was that when I have more skin in the game, when I have to pay more money out of pocket, I'm going to be a smarter consumer and figure out where is the lowest cost MRI or who's the lowest cost doctor, and we just don't see evidence of that kind of behavior. So in conclusion, what we find is, so the pros are several large employers. We have 2 here on our panel who are offering high deductible health plans. There is clear evidence, not only from my studies, but from other studies in the literature, that these high deductible health plans lower healthcare costs in at least the short run, so from 1 to 3 years after these are offered. There is little or no evidence of an increase in ER use or inpatient costs in our studies in the first 1 to 3 years. And there is little or no evidence of a decline in use of preventive care. So we didn't see an increase, but we also didn't see a decline. It was basically unchanged. On the cons, there is going to be a modest increase in premiums for traditional plans or the PPO plans. There's going to be significantly higher financial burden for low-income populations or for those who are chronically ill. There's going to be a reduction in the use of medications for chronic illness, which might have adverse health consequences in the long run. And we don't find that this is making people smarter. So we don't find a decline in use of low-value care or an increase in price shopping. So what's missing from this literature is no one has directly looked at the impact of high deductible health plans on long-term health, to say what happens to people's health when they enroll in these plans and stay in these plans for 4 or 5 years. So I would love to do that study at some point of time in the future. Thank you.
Thank you.
So I'm Samantha DeBridge from Hewlett-Packard Enterprise, and as Kathy mentioned, I'm responsible for their global benefit programs. And today I'll be talking to you a little bit about our U.S. programs and specifically the consumer-based health plan designs that we have as options for our employees. So a little bit about our employees before I talk about the options that we have available to them, because I think we're a little bit different than maybe what you might think about from a high-tech employer perspective. So we certainly have our share of millennials, but we also have an average age of mid to late 40s. We have very long tenure employees in general, so our employees, it's not uncommon for them to be here a decade, 2, 3, even 4 decades. So we've got a bit of a different population than I would say some other high-tech employers have. And when we think about our employee base and what we want to provide to them, we're really looking to meet them where they are and to allow them some flexibility and choice in terms of what's best for them and their families. So we have a strategy where we allow for employees to select from a range of options. And typically, employees would have an opportunity to select from one of these high deductible health plans, or they could select a PPO, or in many cases, a regional HMO. And here in California, they have an option to select Kaiser. As part of our approach to healthcare, we really look at not just the plan design and the selection that they make at that point, but we look at the things that we can build around that structure. So regardless of what program they've selected for themselves and their family, we look at tools that could help them either when they're making the selection or as they're going through the process of needing health care. We look at incentives, but we don't incentivize based on the plan that someone is going to select. So we're not trying to get people into one plan over another. What we're trying to do is incent people to understand their health risk factors, to think about care maybe within a plan, so using a high-performing specialist as an example. But our most common incentives are really around annual enrollment and people completing health risk questionnaires, agreeing to go through coaching if they're smoking or having other high-risk factor behaviors. And then finally, similar to what Dr. Snood said, we actually do seed our HRA and HSA accounts, and I'll share with you in a little bit more about what we do in that space. And then again, across any of the plans that employees select, we want to educate them, we want to promote healthcare consumerism, but we don't typically talk to them about consumerism as the concept. The concept is really about thinking about what you need and what's best for you and your family, having that trusted relationship with your primary care provider so that they can help you navigate a system that you may not be familiar with or that you may not use very often. Again, that strong focus on prevention and wellness. Regardless of what plan you're in, we want people to be having their preventive screening, so we do a lot of education around that, and then we have a very robust wellness program. And then the point that we really leverage across any plan that we have is we're selecting networks that we think provide the scope and access that our employees need, and care management services that allow them to get some additional support beyond their primary care provider. And that includes things like telemedicine, if that's helpful to them, or secondary opinion services. So this is a little bit about the consumer-directed plans that we have, and we offer 2 different programs. So again, in addition to the PPO that we offer and the various HMOs, these 2 are offered nationally to our employees. The HRA program we've had in place for a few years now, and the HDHP with Health Savings Account has been about 18 months, so we're into our 2nd year, so a little bit less data there. You'll see that they're set up in some ways very similar to a PPO in that they have an in and out of network coverage option, they have a deductible, and then they have an out-of-pocket maximum. Some of the things that make them different, though, are these account-based models that exist. So in the HRA, we're funding into that account, and an HRA is set such that only an employer can put dollars into that account. If you look at the HSA, we're also funding into that account, but this is also a place where employees can contribute dollars into the account if they'd like as well. So it gives people in that option a little more flexibility if they think they'd like to put dollars aside for future healthcare expenses, or even have it roll over and help them into retirement. This is a little bit more about just a side-by-side on the differences between the health reimbursement accounts and the health savings accounts. And again, I think some of the things that really drive people to select one over the other is for the health reimbursement account, they can use the funds that are available in that account right away. For a health savings account, depending on when an employer is putting funds in, that contributes to when they can actually access those funds. So if you have an employer that's putting in an amount, a small amount, each quarter or half a year, that impacts when you can actually leverage the account versus an employer who might put the money in up front. You've also got, again, that employee and employer contribution component on the health savings account. So if that's something that an employee knows they want to take advantage of, they need to go into an HSA style of account. And then finally, that flexibility to roll the dollars over exists in both types of accounts, but in the HSA, the money is really there, so when they retire, it's something that they can leverage in the future. And then finally, I just want to point out a little bit about FSAs, or flexible spending accounts, because we've had a lot of employees that have been very used to using these types of mechanisms year over year when they've needed them. And there are some differences around leveraging that type of an account when you're in these models. So if you're in a health reimbursement account, you can still use the FSA the way you would if you were in a PPO or an HMO or any other health plan. But if you're in the health savings account, there's some restrictions, and you end up needing to leverage something called a limited purpose flexible spending account, which means it can be used for dental and vision coverage, and post-deductible medical and RX expenses, but it can't be used towards the deductible. And that's an important distinction when people are planning for their health care and what's best for their families. Okay. A little bit about really our philosophy in leading to adding these types of programs to our selections for employees. So we really do look at choice and tax savings applicability for our groups, but we also think about plan designs that can really help employees be active in their health and be good consumers. And we think that's important across any plan, because as much as we talk about how much does it cost to be in this plan versus that plan, at the end of the day, we're all sharing in the expenses across any of the plans that we offer. And having employees that think about what's best for them and their families, having that relationship with their provider to help guide them through what services they need and where they should have them is important, whether you're in an HMO or you're in one of these types of plans. We look at what we determine as appropriate cost sharing across our employee base. And for us, again, we're not incenting employees to go into one plan or another plan. What we really think about is sort of a flat subsidy amount, and then employees can flex into an HMO plan or into one of these plans, depending on how they want to pay for their services and for their portion. So like Dr. Snood said, some of our employees really would like to just have that consistency of a higher amount coming out of their paycheck, knowing that maybe they're going to pay less if they need services. And others prefer to have a lower amount coming out of their check and then know that they can fund as they need to throughout the year for services. And then managing employee health and well-being is another important component for us. We look to support them throughout the year and across any services that they might need, so physical wellness, behavioral health, and even financial wellness as a portion of our program. And we also provide advocacy services so that regardless of what plan you're in, if you need additional support, if you're not feeling like your claims are being handled appropriately, or you have questions about your evidence of insurability and things like that, that there's someone available to help you with those types of programs. And then finally, the leveraging efficient delivery systems. And we really do believe there's a way to have efficiency within any delivery system. So, and I think Kaiser is a great example of efficiency within an HMO model. So any model can have efficiencies, and we look for those efficiencies across each thing that we offer to employees. So I think the other piece that I just want to mention here is that when you're thinking about accessing care, we really are looking for employees to, and their families, to understand what's really needed for them personally in terms of, you know, their age, their health risk factors, and things like that. And so, again, that shows across any plan that we provide. Okay, and then just a few other comments here before I turn it to Jerry. For us, we spend quite a bit of time each year planning and designing for the next year or for even a couple of years in advance. So we do long-term strategic planning across our health program. We think about education and tools, not just at the point of selecting a plan, but throughout the year. So when they're selecting a plan, it starts with tools that we have where they put in some information about themselves and the way that they use healthcare and the way that they anticipate using healthcare, and that gives them some indications of the types of plans that might fit their needs. And then throughout the year, again, they're getting education on how to use the programs, how to establish a relationship with a physician, and even how to find someone that would be the right person to connect with. And then finally, we look at the regulatory environment. Obviously, we want to be in compliance, but we're also thinking about, you know, how do we help people sort of understand and navigate these things effectively? Because sometimes there's things that if you're not familiar with healthcare and all the regulations, they don't necessarily seem to make a lot of a sense from an employee's perspective and from a family's perspective on how they might use the plan. And so you just want to make sure that they understand for their situations and scenarios what actually plays out within their program. And then the other piece that I personally am really interested in is seeing how these types of plans will change and morph over time. We've already seen some changes in these spaces, and I think, you know, particularly some of the work out of Choosing Wisely, University of Michigan, value-based care design, and other things that are happening in this space could lead to, I think, some things that would really improve the programs in terms of thinking about chronic care, people who have chronic illnesses and what they need to be successful, and how these programs can really support them more effectively. And then finally, I'll just close with some visuals around some of the information that we provide to our employees. And we found that, you know, as I mentioned, we've got an average age in the mid-40s. When I look across these types of plans in comparison to the other plans that we provide, we have about a third of our employees in these plans, about a third in HMOs, and about a third in the PPO. So really very equal distribution across the three types of options that people have. But for the third that are in these programs, they are slightly skewed towards having families. So I find that interesting in that over a third of our employees have families, and a third are in this program, but over 40% of the people that select this plan actually have families. And almost 70% of them actually are in the HSA program and contributing into that fund. So it tells me that they're valuing that component of being able to save on a tax-free basis for either future healthcare expenses or for retirement expenses. I think those are the primary points that I wanted to make about the experience that we've had. And now I'll go ahead and turn it over to Jerry.
Thanks, Samantha. And thanks for the opportunity to talk to you today. So I represent McKesson's health benefits journey. And so a lot of the work that we do is very similar to what Samantha described, the planning, the analysis, and the communications. So we do that on a regular calendar basis every year. I've been at McKesson for 10 years. McKesson is, I think, Fortune 6. We are a healthcare company. We're in all 50 states. We have employees across the spectrum in terms of income, job descriptions from executive CEOs, physicians, to distribution center employees and call center employees. So we have to provide benefits that meet the needs of all those employees, and it is a challenge. But we've been on this journey since 2008. It started with changes that began really in 2010. So I'm going to walk through that journey and describe some of the things that we've done. I think what's important here is that it has been a journey. We didn't just rip off the Band-Aid back when we decided to move into a consumer-directed environment. As a healthcare company, most of the vendors and plans and carriers that I work with are also business partners of the company. So it's a little bit challenging, and our CEO is a proponent of giving our employees choices so that they make the choice. So when I started at McKesson, there were 81 plan choices for our employees to choose from. A daunting task at annual enrollment. Today, there are 3. On January 1st of 2019, there will be 2. Well, 3 if you include Kaiser. But the plan designs, there's 2 plan designs across Kaiser and the other carriers. And Kaiser is our only fully insured model. So in 2019, we will complete our strategic shift to HSA plans. We moved back, I think in 2014 or 15, we offered an HSA plan alongside our HRA plans. So the way we look at high deductible plans, consumer-driven plans, high deductible plans, pretty much the same thing except for the amount of deductible and the way that works. But the difference is the accounts. So a health reimbursement account versus a health savings account. The health reimbursement accounts were really intended for employees to think about that as their own money, but it really wasn't. It was the plan's money. But it was intended to help them have skin in the game and to think about their choices when they were making healthcare decisions. In an HSA environment, it is their money. So at McKesson, we give them a contribution. If they choose we have two designs, HSA Plus and HSA. The HSA Plus, the plus refers to McKesson's contribution. That contribution is made all on January 1st each year. And then the employees contribute to the extent they would like to over the course of the year through payroll deductions. But McKesson's contribution is made all at once. We contribute depending on your coverage tier. So if you're just covering yourself, employee only, it's $750 a year. Employee plus spouse or employee plus children is $1,100 a year, and for full family, it's $1,500. So that money is theirs on day one. The design for the HRA plan is exactly the same. We still have 4,000 employees in that HRA plan. That will be eliminated at the end of this year, and they'll be basically forced to move into an HSA model. Really, our guiding principles, I think, are important here. As a healthcare company, we really wanted to focus on healthy behaviors and a healthy and productive workforce. We see that as our best competitive advantage. It's challenging to attract and retain folks. A lot of people think that because we're a healthcare company, we should be offering the best healthcare available, which in their mind, I think, primarily means 100% coverage, which we certainly don't. Our CEO, when I joined McKesson, had just written a book called Skin in the Game, so that was really our guiding principle, as you can imagine. We're hoping to lower our healthcare trend, so I was surprised by the actual reduction in cost. We have not seen a reduction in cost. What we've seen is a reduction in trend. And so it's worked. We try to beat national trend every year, but we do expect healthcare costs to go up. So the next few slides really walk through the years starting in 2012. One thing I think that's important to point out about McKesson's benefits package is we offer a very robust wellness program, and it's not a separate benefit. It's really embedded in our health benefits, and we offer employees points for the activities and the behaviors that they participate in. That includes things like, exercise, working out, but also for those folks who may have medical issues and can't do that, there's a lot of online courses, and it's just very comprehensive, the kinds of things they can do. They earn points. Points turn into status, and status gives them a reduction in their healthcare costs. So we offer contributions to our health plans on a salary basis. So there's 4 salary bands, and so lower paid employees pay more to select a health plan. And then they pay, do I say lower employees pay less to participate in the health plans? We're not that bad. And then if they achieve status in the wellness program, then that gives them even greater discounts. The HSA plan, the company does not contribute to their HSA. The employees have the ability to contribute up to the maximum allowed. And the contributions are very, very low. For 19, we're actually holding them flat. You can see what the financial results are at the bottom of the slide here. So we had a surplus in 2012 and a surplus in 2013. 2014 was a bad year. We had an almost $20 million deficit. It's a very painful year for me. At that point, we were offering our carriers, which is Aetna, Cigna, and Anthem, across the United States. So not only did employees choose between their plan design, they also chose between carriers. It turned out to not be a very effective approach. We thought competition would drive better results, and we found that the carriers really don't differentiate amongst themselves. The best thing they do is pay claims. So in 2019, we're going back to a best-in-market approach where we offer 1 carrier per state. So we started out with our wellness program offering a discount for the lowest level of vitality status, which is our wellness program. And then in 2015, we gave an increased reduction if you achieved gold status. We offer tools and resources like Castlight, a transparency tool to help people make better healthcare decisions from a quality perspective as well as cost. I would say that it's modestly utilized, certainly not seeing the utilization that we'd like to see. But it's slowly getting better. And then, so you can see in 2016, we made the HSA Plus plan available. That really was the move to really deeply into the HSA environment. And I think at that point, we made a conscious decision that we were going to move away from the HRA, the health reimbursement account, towards that health savings account. So we did a lot of employee meetings, and I always like to go out to the distribution centers. These are employees who don't sit at a desk, they don't have a computer available, and they're walking around, packing and picking product all day, and they were quite surprising to us. By the way, some of our folks are covered by collective bargaining agreements. Not a large percentage of our population, but out of 25,000, maybe 3,000 employees across the company. And most of those participate in the company programs. So we made a conscious decision to talk to all of our folks that were what we call non-wired. And I was amazed at how well they understood the plans and the changes. And what was most significant was they realized very quickly, so some of them had very large HRA balances, those balances rolled over every year. And the most common question I was asked was, so what you're telling me is if that was in an HSA, that really would be my money. So they really understood that the difference between HSA and HRA. We thought that was really important. So our costs have leveled off. We eliminated in 2017 the last of our regional HMOs. We also have a limited purpose FSA. So we really look very similar, except we don't have a PPO. So in terms of our long-term planning, so I mentioned, we froze the HRA core plan. That's at HRA, the last of the HRA plans, and that ends at the end of this year. So this year we have an extensive communication strategy in place, already started, to remind these employees, they learned last year their plan was going away, reminding them that their plan is ending at the end of this year, and that they would have to move into the HSA plan. One thing I want to mention is that, originally this HSA strategy was, I think, in some ways forced upon us by the Cadillac tax that was looming. I think is still looming, but I don't know if we'll ever see it. So I think, we all knew that we had to do something to prevent that from happening. But from our perspective, and I'm going to talk about the results, the HSA strategy has worked well. So for 19, we're eliminating the last of the consumer-driven health plan. We're moving our plans to a best-in-market approach. We're adding autism support benefits, and we're adding benefits for part-time employees. Currently, if you work 30 hours or more, you're eligible for benefits. Looking forward, we want to enhance support of on-site health coaching, support for employees to access appropriate channel of care, improving the employee experience. It's very confusing, we know that, and we're really trying to improve that. That is a daunting task. Oops. So what we talk about is, we are very concerned that our employees would avoid care because their out-of-pocket was greater or could be greater. And that hasn't been what we've seen. So some key facts here are office visit utilizations increased by about 2%. Emergency room visits decreased by about 3%. Now, to be fair, I think part of that ER visit decrease is the growth in urgent care centers. So we've seen an increase there. In terms of prescription drugs, we were worried that people would not adhere to their medications, but the day supply of prescription drugs up nearly 8%, and generic efficiency rate up by over 1%. So we think that when employees are using their own money, they make better decisions, or at least if some of it is. And we certainly see the seasonality at the end of the year. But preventive care has always been covered at no cost at McKesson, long before ACA. So I think our employees are very well aware that preventive care is covered at 100%, and they do take advantage of it. It's our number one expense line, preventive care. So I think, and the other thing is with HSA, we have a preventive drug list. So if it's generic, it's covered at 100%, not subject to deductible. So we are as aggressive with that preventive drug list as we can legally be. And in 2018, we added a brand component as well. So that I think primarily because insulin doesn't have a generic equivalent, and so we wanted to make sure our diabetics had access to the drugs that they need. We do a survey every year, and this is just some of those results. So just in terms of enrollment, the HSA and HSA Plus plans grew in enrollment. The HSA plan, that's what I sort of refer to as that bare bones plan. The company doesn't make a contribution to the HSA, grew by 17%, and the Plus plan grew by 25%. And then the numbers of employees contributing to their HSA increased by 17%, and the average contribution increased by 7%. 80% of our employees say they have a good understanding of the healthcare plans that we offer. And affordability is perceived as the #1 influence on HSA contributions. And 73% say that the benefits meet their needs. So we think we're doing well. But it is early for us. We're only a few years in, so we'll be looking closely. I think you need this, right?
Good morning. My name is Dina Mendelsohn. I'm a senior attorney at Consumers Union, the Advocacy Division of Consumer Reports. Yep, this Consumer Reports. In 2016, Consumer Reports Online reported on concerns raised by high-deductible health plans. We explained why these plans are concerning for our readers, and we provided suggestions to consumers on how to rein in their out-of-pocket costs while also urging them to not let their insurance coverage affect their health. As we've heard today, high-deductible health plans did not come out of nowhere. There is a purpose to them. The theory behind high-deductible health plans, as you've heard already, is to get more consumers to have more skin in the game. The idea is that when consumers are more conscientious about their spending, we can all save healthcare dollars and improve efficiency. Those, of course, are laudable goals, but they've been assigned to the wrong players in the healthcare world. High-deductible health plans force consumers into the driver's seat in solving a major national issue that's really out of their control. While HHPs won't fix the problem that they're meant to solve, they create new ones, jeopardizing the health and financial welfare of enrollees. On an individual level, the promise that we give to consumers that in exchange for HDHPs, their premiums will go down does not exactly pan out. While the premiums do go down, the overall costs for consumers are up. Between 1980 and 2016, out-of-pocket costs grew from $250 to $1,400. That's a nearly six-fold increase in medical bills, and while most employees did not see their wages grow that quickly in that period of time. Between 1973 and 2016, hourly compensation of a typical worker rose only 9%. Just think of that, a worker's wages goes up 9%, but the out-of-pocket costs go up about 600%. Now, deductibles, that big bill that has to be met before insurance really kicks in, and which is the foundation of these high-deductible health plans, are also growing much faster than workers' wages. Between 2006 and 2017, average deductibles for people with employer-sponsored health coverage went from $303 to $1,500, or it grew about fivefold. Again, that's about a 500% increase, and wage growth during that time was strong, but by no stretch of the imagination did workers experience that big a salary increase over 11 years while their deductibles were skyrocketing. HHPs are designed to have enrollees have more skin in the game, but in this case, enrollees are getting thrown into the game with little protective gear in some cases. Plus, shopping for healthcare is different from shopping for other things. Since I'm coming from Consumer Reports, I'm going to give the car analogy. So when you go shopping for a car, you more or less know how much you're going to spend and you have some control over it. If you don't want to spend a ton of money, you're probably not going to buy a luxury car. But if you find the car that you want, you have a general sense of how much it's going to be when you go to the dealership. If you don't want to pay $3,000 more, you probably will not get the leather upholstery. In healthcare, it's really difficult to know how much different aspects of care are going to cost, which of them you actually need, and it's difficult to get information about quality. Shopping for healthcare will never be like shopping for other things. The stakes are too high, the amount of relevant and accurate information is too low. Plus, it is very difficult for the average consumer to understand their insurance products and their complex benefit design. Further, even the most diligent and informed consumer is unlikely to make a meaningful dent in overall healthcare costs. According to one report, only 7% of healthcare costs are shoppable and out of pocket. Further, only a fraction, and I'm talking around 1 to 12%, of patients who are offered web-based or app-based price transparency tools actually use them, and fewer use them before receiving care. This is true for patients regardless of whether they are low income or higher, or regardless of low or high deductible, and even among the uninsured patients who presumably will have to pay full bore. Even to the extent that price shopping and learning to price shop occurs, it does not meaningfully contribute to reduced spending. That could change over time, but a lot of variables would also have to improve. Many patients are not aware that price data is available, and for those who are aware, the complexity of medical payment and billing systems undermines their price shopping. What's more, price transparency tools that do exist for consumers who are willing and able to shop around are of limited use. Many price transparency initiatives report total price. Some tools offered by employers or health plans estimate out-of-pocket costs for patients, but it is very difficult to get that number right. In order to do so, they would have to have the provider's price for each individual health insurer, and they would also have to have real-time access to the benefit design of the insurer and the patient's health spending to date in that year to give an accurate picture of what the patient will be spending. A few years back, my colleagues at Consumer Reports wanted to see how various healthcare price and quality transparency sites stacked up. The slide shows our rates for insurance company tools. You'll see in the far right column, nearly none of the carriers scored well for display of healthcare value, the measure of cost and quality of care. This is the exact type of thing that consumers with more skin in the game should be shopping based on. But based on this, they're going to have trouble getting the information they need to do that shopping. My colleagues also looked at standalone websites that look at cost and quality. There is a lot of orange here, and orange is a pretty bad color when it comes to Consumer Reports. The top-rated site, Amino, earned a 66, and for those not familiar with our scoring system, we score out of 100. So 66 is really nothing to boast about. And these are the tools that we're offering consumers and telling them to make major decisions that will affect their health and financial welfare. I think it's fair to say that quality and price transparency tools aren't where they need to be for us to shift this burden onto consumers. So where does a patient go to get information to make the right decision about himself or his family? Choosing wisely and other programs are some of the options. But another option is to go to the doctor's office. It has been in the doctor's all along. The patient could actually go to their provider and ask for advice. In a story on Consumer Reports Online, our medical director, a practicing neurologist, walked her patient through his decision of where to get an MRI. The patient figured out that prices varied widely, but he wasn't sure why there was this price variation and how to pick between them. So the medical director explained to him the differences between different MRI machines, and the patient used that information to make a decision about where to go. This is information that he could not find on his own. Instead, he got it from his doctor. But how many enrollees do we think will have this type of conversation with their provider? And how many providers know about the cost and the device mechanisms to give their patients useful information? And finally, how much time do we expect or want our enrollees to take out of their day to do the research that they need to do to avoid unnecessary cost and high costs? Ultimately, HDHPs introduce a barrier to care for consumers. Studies show that HDHPs signal to policyholders that they should not go to the doctor. Cost sharing like this is an effective but blunt instrument to control health spending. Medical spending might go down, but it appears that so too does healthcare across the spectrum of procedures. Notably, sensitivity to healthcare costs extends across all income levels. And in a study looking at healthcare consumption among a cohort of largely well-off employees whose coverage was converted to an HDHP, the researchers found the spending went down about 13%. These spending reductions came in part from well-off and particularly sick consumers, they reported, who were facing low yearly out-of-pocket maximums. Moreover, consumers reduced spending almost exclusively by lowering quartiles of the quantities of healthcare services rather than through price shopping for cheaper services, or indirectly by having access to lower priced providers over that time. Enrollees spend less overall when they face high cost sharing, but they do not necessarily spend more wisely. table is very interesting because it shows the two different types of drops in healthcare by HDHP enrollees. Remember, these were high-income enrollees facing reasonably low out-of-pocket maximums. Yet the responses to having more skin in the game appears to be to stop playing. Utilization is down for both low-value care, which we heard about earlier, as well as high-value care. So these enrollees reduced their use of unnecessary antibiotics for colds by about 44%, which we would say is a positive outcome, but they also reduced their use of diabetes drugs by 48%, and their use of hypertension drugs by 24%, as we heard about a little earlier. There's also the question about what's going on with free health care, the preventative care that consumers should have access to without actually paying a cent. And what's interesting is that in studies that I found, free health care actually dropped among consumers who were enrolled in HDHPs, which seemed pretty counterintuitive. And so at this point, I've seen two different theories about why consumers would stop getting this free health care with their HDHP. One theory is that some consumers are getting this free care when they go into the doctor for something else. So they're not going out of their way to go to the doctor and get this preventive care. But if they're going to be there anyway, they'll get this done. But now with the HDHP, they're delaying going to the doctor at all, which means that they're also not getting this care that would otherwise be free. The other theory is that consumers just don't understand how their health insurance works. And this is something that you've heard several times today. Health insurance is complicated. You know that you have a high deductible. And consumers are not putting it together that free healthcare is free healthcare whether you've met the deductible or you have not met the deductible. So some are actually holding off on it because they don't realize that it's free all year. High deductible plans can have harmful and sometimes irreversible effects on employees' health. According to a 2015 survey by Families USA, almost 30% of people with deductibles higher than 15% for the individual coverage avoided medical care. That includes tests, treatment, follow-up, and prescription drugs because they couldn't afford the out-of-pocket costs. As you recall, some drop care is low value, and so that's not so much a problem. But when high-value care is skipped, that could be a real issue. Patients that put off necessary care can end up needing more care and spending more later. In our Consumer Reports article, we detail one such story of Monique Dow, a 46-year-old mother of two, who had a $6,000 deductible with her family's health insurance plan, which was the only plan offered by her husband's employer. For months, she put off surgery to remove what her doctor thought were benign fibroid tumors and polyps in her uterus, and when she eventually scheduled surgery after working out a payment plan with the hospital, the polyp was found to be cancerous, requiring a hysterectomy. Ms. Dow put off necessary health care because of her high deductible, and while she waited, a cancerous polyp was growing. Like I said at the start of this talk, HDHPs are not without purpose, and that is to rein in healthcare costs. HDHPs are not the solution that we need, however, and there are better ways for employers to partner with employees to rein in the cost of care. For example, we strongly encourage people with power over insurance products to rethink benefit design. We suggest putting all or most of outpatient services outside the deductible, such as is done with the plan sold on Comfort California, and creating affordable and predictable cost sharing for enrollees. We also support reference pricing, which makes consumers responsible for the last dollar of care rather than the first dollar of care, which hopefully will mean that patients will focus on where to receive care, not whether to receive care at all. Value-based design is also another valuable avenue, which focuses on the quality of care rather than financially rewarding providers based on quantity of care. And no matter how health plans are structured, and this includes HDHPs, enrollees need usable information that will help them distinguish between low and high value care, and to identify preventive care that's actually free or low cost. And I think this could actually explain why McKesson did have these positive results that run a little contrary to the studies that I found. It sounds like they did a great job educating their consumers or their enrollees, and that in turn made the enrollees able to use their HDHPs in a more positive way than some of these studies that I was reading. And finally, optimizing the provider network can be a valuable tool for controlling costs. Health plans should identify providers with strong track records based on patient outcomes, so consumers can see providers in their network with confidence. There is a sweet spot for network size, and the race to cut costs by extreme narrowing a provider network is also not the solution. So thank you.
Dina, can you just advance the, thank you, there you go. So we're going to now introduce some discussion topics. First, we're going to ask one question of our panelists, and they have 1 to 2 minutes to answer. Then there will be a second, and then we will open it up to board questions. The first question: do high deductible health plans discourage patients from seeking the care they need? And with that, I'll start with Dr. Sood.
Sure. So I think based on the evidence we've looked at, especially for drugs for chronic conditions, I think there is clear evidence that once people enroll in high deductible health plans, they reduce the use of drugs for treating chronic conditions. So I think that's evidence that they are reducing, patients, or they're discouraging patients from seeking the care they need. And I think Consumer Reports survey or other surveys also confirm that.
I think from our perspective, we haven't seen that in our population. For the HSA, we're pretty early on, but so far we haven't seen that it's discouraging patients from seeking care. I would say, though, that you could really, plan design is very important. You could discourage people from seeking care really within any plan design if you're not thinking about the population that you're trying to serve and designing something that's reasonable for them. So I think that technically could happen within any design, and I would say within our programs, we haven't seen that yet, at least within our first 18 months.
Yeah, I would agree with you, Samantha. With respect to McKesson's plans, we haven't seen it either. I think one of the reasons that it has worked for us is we incentivize. So I know there's probably a lot of disagreement on whether incentives work, but they've worked in our population. And so we give points for an eye exam. We give points for your annual physical. And we give points for your age-appropriate screenings, mammograms, et cetera. So our employees are encouraged in more ways than one, other than the fact that it's covered. They're encouraged from a wellness perspective. I also forgot to mention earlier that those points that they earn turn into bucks, as we refer to them, and then they can use those dollars to get Amazon gift cards or all kinds of things. So and they see this really holistically, and over the years, it's really changed the way they look at it. So I think Samantha really nailed it when she said plan design is really important. So I think it's really key to be thoughtful about how you design those elements so that employees are not discouraged from seeking care, and they understand the importance, and that the benefit plan designers understand the importance and monitor those elements.
I think my answer will be predictable based on what I just said, but it does appear that with the caveat that different employers are coming up with different benefit designs, but overall research has shown that it does discourage patients from seeking the care that they need. There are ways that you can plan it so that it's less likely to discourage patients from getting the care that they need. But then there's also the additional factor that we're talking about when we look at health coverage. We're also, in addition to health outcomes, we're also looking at financial security. And so when a consumer is paying more, when they go to the pharmacy counter and they realize that they're paying substantially more for their prescription drug, they're going to end up making a very difficult decision whether they should fill that drug or whether they should pay their rent or get their groceries or things like that. So there are also the externalities that we worry about. But to go back to answering the question, yes, clearly we think that they do affect consumers, how consumers access the care that they need. But I do agree with the other panelists that it depends exactly how each employer sets up their benefits, the extent to which consumers will be affected.
So going back to the issue about plan design, what we find in our research is that if you combine a high deductible health plan with a health savings account where the employer is contributing money to the health savings account, so then these kind of behaviors will be less, but the cost savings are also lower. Because now, there's a difference between a plan where you have a $2,000 deductible and zero money in your health savings account versus you have a $2,000 deductible and your employer is contributing $1,500 every year to your health savings account. So in the latter plan, the cost savings are less, but so the risk is also lesser that people are going to forego care that they need. The other aspect so a lot of employers now are not giving their employees an option. So they're called full replacement employers. So there's no option, everyone's going to be in a high deductible plan. That is going to have a different effect because you're forcing people to be in a high deductible plan versus giving people a choice. And if they're making a conscious effort, maybe they're the smarter consumers, maybe they're the ones who can navigate their health plan, and the results might be different there.
Second question for our panelists. Why aren't other tools that influence provider charging and consumer shopping used instead of high deductible plans, such as reference pricing or value-based insurance design? And I think I'll start with Samantha and then Jerry.
I would say that they're not mutually exclusive. I think it's important to sort of have a multi-pronged strategy. Everyone is struggling with the rising cost of healthcare. So our employees are, we as employers are as well. And so we try to provide as many options as possible that we think will help our employees and will help us control healthcare costs. So we do have several tools that we encourage people to use, and they also have options. So they can select within, again, an ACO or an HMO model if they want, or a PPO, or these high deductible designs. And regardless of design, we're asking people to think about the healthcare that they're using and to partner with their physician to make good choices. And we have tools available for them to also evaluate the decisions that they're making.
Once again, I agree with Samantha. They're not mutually exclusive, and I think that we do try to implement, provide all of these tools and resources. We have not done reference-based pricing, but we have done value-based design with respect to drugs that required employees to participate in a care management program. I think the problem with that was the care management program wasn't very effective, so we're looking at that. I think the other piece is with all of these components, and there's so much in development right now and so much available in the marketplace, we have to be careful about what we make available. It can add to the confusion and the, how do I navigate this system? So I think that comes down to the employee experience, which I mentioned. I think that's a challenge. How can we help our employees know where to turn? I think one thing that's really important is, so Dr. Sood talked about people not reading the materials, not understanding the materials that are provided, and we provide a plethora of materials. The people want just-in-time information. So if I need to have knee replacement surgery, I'm not concerned about that until I begin to know that. Often, so in the case of cancer, for example, I find out at the doctor's office and they send me directly to an oncologist. That might not be the best provider for my situation, but I'm already on that pathway. So if I provide tools to help an employee choose or a patient choose the best pathway, they may not even look at it because they're already following the direction of their doctor, which may or may not be the best pathway. So it's a daunting challenge. I think there's lots of reasons why the tools aren't used more frequently, and the consumers are just baffled by it. So.
Can I add one thing to what you said? Because we too have struggled with the reference-based pricing, and I would say some of the work that CalPERS did in this space really was at the forefront of bringing these to all employers. And so We're hopeful that in the future we'll have better opportunities to use reference-based pricing because I think there's some power in that. But that is one of the things that you list on here that hasn't really been available in the open marketplace, and you may not be aware of that because you've had the opportunity to participate in those types of programs here at CalPERS. But generally, as employers, when we're talking with vendors, that's not an option that is typically offered on the table. So as more comes out from the studies that you all did and from some other pilots that were done in other locations, we're really hoping that that's a place that we can also try in the future.
It's actually a question that I cannot contribute too much information on. We've always been pushing these other ways of handling high healthcare costs, as you heard in my presentation. So it was very interesting to hear about the different reasons, but it does make sense that it would be more complicated. And again, with the reference pricing, which is something that we do support, that's another area where you would have to really have some really great education for the enrollees, because otherwise it might look to them like their choices are being restricted and people get uncomfortable with that. But we continue to encourage it and understand that it's going to be complicated.
Just following on Dina and Jerry's comments, that we might just have the wrong target here, that in the sense, it's your doctor or your primary care physician who makes most of your healthcare choices. So in some sense, that's the person who needs the incentives, not the consumer. Because now if you provide consumers the incentive and your doctor doesn't have the same incentives, it kind of creates this friction. And that's why I think a lot of these tools don't work, because they're kind of targeting consumers, or they don't work to the extent they should. So I think in some sense, targeting physicians and figuring out and helping consumers make good physician choices. So for example, we did a study where we said, okay, if you go to a more expensive physician, that more expensive physician costs $50 more, not a big saving. But that more expensive physician refers you to more expensive MRI providers, more expensive labs, and so on. So now if you add up all those services, that's $1,000 saving. So I think the choice of physician is important, and then incentivizing the physician. So there was a study done in Massachusetts where they gave physician incentives, and now what happened was, it wasn't that there were fewer MRIs, but the physicians were referring their patients to facilities that offered cheaper MRIs. So the physicians were, in some sense, price shopping for their patients. So I think there's a lot of evidence that changing incentives for doctors or providers works, that they do respond to financial incentives. Doctors are not saints. And that's the way. They're the more knowledgeable party, so that's the way to make healthcare more efficient.
This is the last question that I'm then going to turn over to our president and our Pension and Health Benefits chair so that they can lead the discussion. So we've put this out there as a possible question, or we welcome other questions as well. This question is, are high deductible health plans trading short-term savings for more expensive care in the longer term? So Madam President, Mr. Chair, go ahead please and lead the discussion.
Thank you. Well, I do think that is a key question. And it sounds to me like Dr. Sood answered it to some extent, particularly around the pharmaceuticals, and if people are opting out of drugs that they need, maintenance drugs like diabetes drugs and statins, then that could result in longer care over the long term. But you haven't actually done the study at this point, is what you said, I think.
Yes. So I think there isn't any study. So it points to some adverse consequences in the long run, but there isn't any study which has directly looked at that and shown that. And in the studies we've done where we've followed individuals for up to 3 years after enrolling in high deductible health plans, we see that those savings persist. So the savings are not disappearing, but we haven't followed people for 10 years, or we haven't modeled what would happen to them in the long run. So I would say the answer to this question is still like inconclusive. We really don't know the true long-term effects. There's some pieces of evidence, the drugs, that points to worse outcomes in the future. But when we just look at healthcare costs over a 3-year period, we don't see them rising, or we don't see an increase in hospitalizations and so on.
Okay, but 3 years is not really long-term. So, okay, so are there any questions from the board? Yes, Mr. LaFaso. The middle, yeah, there you go.
Thank you very much, Madam President. Really great presentation. My question's primarily directed to Ms. Dubridge and Ms. Burwell. Did I get that right? Burrell, thank you. So when I came into the presentation, the word consumerism was featured in your slides, and I really wanted to get my head around the process of employee decision-making on healthcare, which seems to be the core of the skin of the game discussion, and you mentioned the wellness programs and the tools. But in some of the examples that you discussed in your presentations on things that employees were learning as the programs were changing, we're very focused on the financial devices, what the non-purpose, say, FSAs coupled with the employer contributions, all this kind of stuff. I'm wondering if you can comment on how much of the employee decision-making process is around the money, how to figure out, how to manage their money, versus how much is influencing the actual process of employers making healthcare decisions, whether it's shoppable services and all of the things that we talk about on the healthcare side of the equation.
I can start. I think, there's a couple of different things when you're thinking about healthcare. Obviously, you're not purchasing widgets. That there's an emotional component to it. Sometimes when you're at the point where someone is asking you to shop, you're not feeling well and you're vulnerable. And so the concept that we really hold true to is something that Dr. Snood mentioned about wanting people to have that relationship with their physician so that they can do shopping for some of the things that, maybe it's an MRI or something that they feel a little more comfortable with. But when they're at that point where they're getting a cancer diagnosis, that's not the time to show up with a tool and say, go figure out of these, 50 physicians in your area, who's going to be the most cost-effective for every procedure that you might have that you've probably never even heard of over the next, many months. So there's a piece of this that is more about sort of setting the right foundation. And the other piece that I think is really important is around the decisions that are less about how much is something costing you personally from a financial perspective, but what does it cost you from an emotional or a family perspective? So getting those early screenings, being diagnosed stage 1 with cancer is very different than being diagnosed at stage 4. And so making sure that employees understand based on their personal risk factors, their age, their sex, their family history, et cetera, when they should have screenings is really important. And we even go a step further in having a lot of things on site for people. So we have the mammography unit show up to multiple locations every year. We have dermatologists come in and do skin cancer screenings because California and a few other states, we have, a fair number of skin cancer issues. And so we really try and talk to employees about their health care from a multitude of perspectives. And that's why I had said earlier, we don't tend to use the word consumerism with our employees. That's not what, when we're talking amongst ourselves, that might be what we call these things. But when we're talking to employees, it's more about educating them about a very complicated system and then helping them pick the right people to help them through their healthcare journey, just as they would when they're picking maybe a pediatrician for their child, which people tend to spend more time on than really what they're spending on themselves. And so we're encouraging people to do that as well. So hopefully that gets a little bit at what you were asking.
I think the other thing that I would add to that is helping employees be advocates for themselves. So some of the tools and resources and concierge services that we provide is to help them do that, to help them know that they do have some power. They're not powerless when they're seeing a provider. They have the ability to ask questions and understand what the treatment is that's being recommended for them. And I think, we would like there to be more information. I agree, we don't use consumerism so much anymore. When we first started out with CDHPs, consumer-directed health plans, we used it a lot. And I'm not sure that our employees and their families and patients really knew what that meant. And I'm not sure they still do. But I think what they need to know is we want them to be as healthy as they can be and to be able to access the right care at the right time. I think that's a very daunting task. It's very challenging to be able to do that. But that's really what our goal is. And I think, so I'm not sure that they'll ever be able to shop for other services, healthcare services like they would, a TV. But I think there are instances that they can do more, where they can do more than they think they can, or that they have the ability to influence that market to some extent. And I think that would be a very positive change.
Thank you. Mr. Slayton, did you have a question?
Yes, I did. Thank you very much, Madam President. So it seems to me what I'm hearing is that, of course, consumers left to their own devices, it's daunting. Clearly, it's daunting. But it seems that plan design by the employer seems to be the critical piece, because at the end of the day, what I think we all have in common, the two companies represented here in CalPERS, is we want people to be healthy. Because if they're not healthy, then they're not productive, they're not contributing to the effort of the organization. So it's very clear we have to have that. What I wonder, and Ms. Dubridge, on the issue of how many employees total are within HP plans?
Globally, we have about 70,000 employees.
70,000. So, and you're one-third, as you indicated. So do you see between particularly between the HMO and the HSA plans, do you see that creating a cost shifting where the HMO premiums have gone up significantly or not as a result of the shifting to HSAs?
Yeah, I haven't really seen that. I would say that unlike the consumer-directed plans that are offered across the nation, the HMOs are regionally focused, so it's sort of a smaller subset of people. But what we've tended to find is actually people that are going into the consumer plans more likely have come from a PPO environment. So, the Kaiser membership tends to be very loyal to Kaiser, and some of the other HMOs back east sort of engender that same thought process. So while we've had some movement from the HMOs, it's more typical that they would come from PPOs or plan designs that we used to offer.
Another thing that I think several of you may have commented on is the issue of people under these plans maybe not taking their maintenance drugs. And it seems to me logically that if we want people to stay healthy, that, for example, in the plan that I'm on, I'm an asthmatic. So the medication that I take has a zero copay. So I'm encouraged by my employer to make sure to take that medication to prevent some long-term, even more expensive result to occur. So do you see that as one of the vehicles to try to keep people, regardless of the plan design, that issue of the statins, for example, those things being carved out, especially the ones that are generic, seems to me that we're penny wise and pound foolish if you don't carve those out and make sure your employees are taking them. Do you have a comment about that?
Yeah, I was going to say, Jerry had commented during her presentation a little bit about this, but there is actually a drug list where it's a zero copay amongst these types of plans. I think part of the challenge, though, is with several medications is just regardless of what plan you're in, there are people that tend to not stay on medications long term. And I think things like high blood pressure medications where it's sort of this silent disease where people oftentimes don't even really have a lot of symptoms, that after a while they sort of decide, well, do I really need to take this? And they sort of drop. So there's compliance issues across multiple plans, and I think when these plans were developed, there was a drug list I'd really like to see the drug list expanded somewhat, similar to the things that I talked about in terms of some of the chronic diseases that are maybe not covered appropriately within those mechanisms to have them free. I'd like to, personally, I'd like to see some changes in that space. But I do think that there is a list that covers quite a few. And Jerry or others, I don't know if you have comments on that.
So basically what you're referring to is also a fancy word for that is value-based insurance design. That's basically having drugs for chronic conditions be free or low cost. So there's evidence that that definitely works or that's a smart decision. But I think you need to combine that with, so I'm only going to take statins if my doctor gives me a prescription for my statins. So you want to make sure that people who are at higher risk actually have access to their doctor and can get the prescription for the statin, or their lipid panel doesn't cost them $1,000 and only cost them a reasonable amount of money, so they do get their health screening and so on.
Okay. So one last follow-up question. On the other end of the scale, where you talked about the cancer diagnosis and the protocols that are going to take place, which now the cost for treating that becomes, can be very, very significant. So the question is, are any of you in plan design encouraging, when you have a major event like that, second opinions? Because the number of misdiagnoses and recommendation of treatment that's not the right treatment and maybe not where that patient should be. What are we doing? What do you see happening about that particular aspect?
So one of the tools and resources we provide is a second opinion service through Best Doctors. And it's not limited to cancer. It's available to across the board. But we strongly encourage people to use that service for exactly the reason you described.
Do you have measurements on that, on what the results have been?
So it's only been a couple of years, and for those that have used it, there have been, and I'm not, off the top of my head, I don't know the stats, but there have been a number of changes in diagnosis and more frequently change in treatment, the treatment patterns. So yeah, it's significant. And I think one of the things is that the patient is worried that I see Dr. Jones and then Best Doctors gives a second opinion. Dr. Jones is going to be offended that I've sought a second opinion and that the treatment might be changed. And in fact, that is not shown at all. I think that the physicians generally appreciate the service. That has not been an issue at all. So,
Thank you. Okay, Mr. Slayton, I'm sorry, we have to move on to other questions. Ms. Taylor.
Thank you. And Ms. Donaldson, thank you very much for bringing this panel together. I appreciate the presentation. I had sort of a commentary and then a couple of questions. I think I was going to follow up on what Mr. LaFasa had talked about, promote consumerism throughout the year. And I know you guys said that you don't like to use that with your members, but I think looking at it as a consumer product, and this, I discovered this in the 1980s when healthcare was being referred to as a consumer product. It has always struck me the wrong way. I don't feel like our healthcare should be a consumer product. That is my opinion. I did have a couple of things I wanted to bring up. I have a Bloomberg article here in which, Dr. Sood, you are quoted. But it talks about these high deductible health plans, and I think that your I'm trying to, Jerry, Ms. Burrell, and I can't see your names because it's too far away. Ms. Dubridge, I think that you guys have, it almost sounds like you have a value-based design plan, because based on what I'm reading in this Bloomberg article, most of these large companies have switched to the high deductible health plans. They don't cover any of the statins or the diabetic medications. They don't work with their employees very well. And a lot of these companies now are switching over. And this was the article that talked about Warren Buffett and Amazon and those folks getting together to create their own healthcare plan. The quote from Dr. Sood is nothing that you hadn't said here, basically, which is health deductible plans do reduce healthcare costs, but they don't seem to be doing it in smart ways. I agree with that. I think that we have seen over the years, because this started back in some years ago, and I think it really took off after the recession for employers to switch costs over to the employees for their health care. I think it's also to call it consumerism. It's very difficult for me as a patient to go look for cheaper ways to get my health care when I'm worried about, oh my God, they just found a polyp. What am I going to do? So that's not the first thing on my mind is, okay, where do I go for, the cheaper surgery or outpatient surgery? I have an HMO that's supposed to contain those costs, but as you look at these high deductible health plans, one of the stories they talked about in here was, it was a young woman, a 40-year-old woman who ended up having a gallbladder issue, and then her husband got sick, and they're bankrupt at this point. So these plans are basically shifting all these costs onto the employees. And I think I wanted to ask what are your deductibles? Because it sounds like you guys bring in screening trucks and all kinds of things so that you do a lot of the cost sharing and bring it on the employer. So these high deductible plans, what are the deductibles for the employees? And then what do you guys cover in the difference of, which it makes me, there's where I'm a little confused about if this is a true high deductible plan.
So my design is in the presentation if people want to refer to it, but our deductible is $2,400 for a single employee, and if they're covering a family, it's $4,800 under the high deductible plan. And then we do offer a seating account. And I will say, I do think some of the points that you describe in that article about chronic illnesses is part of why I'd like to see some modifications personally made to how these designs are regulated. That's part of why we provide the seating that we provide to help support employees in those situations and others. But the plans, they have great features, but they also have features that need some work, I think. And so employers who are really looking at these programs just like they would any other and trying to come up with something that makes sense for their employee base will build what they think makes sense around the program, similar to what we've done. So we build a lot of things from a wellness perspective. We have support mechanisms for advocacy, for second opinion, for teledoc services, for a lot of other components that we think will help employees, but it's about helping them in this plan or in whatever other plan they think is effective for their family.
So even Kaiser, is that what you're
So,
saying?
yeah, even Kaiser, people can get these types of services and get that kind of support. And the other thing I would just say is it's important to balance. It's not, healthcare is not 100% about cost, even though we spend a lot of time talking about cost. I don't think any of us would say, go on a tool, figure out whoever is the absolute cheapest, and that's always the right answer, because the absolute cheapest may not be the best quality, and they may have you coming back to the hospital multiple times after a surgery or something. So at the end of the day, it may not be the cheapest. So it really is important when you're looking at all of these tools and resources that are available that you're really looking at what the quality measures are. These are huge networks of physicians, and the quality is different. So you need to look at the quality piece and the cost piece when you're out trying to make decisions or when you're talking to your physician about making those decisions.
So we're bumping up against the
Yeah.
time for a break.
Okay.
So we have two other board members who want to ask questions.
Go
So
ahead.
if it's okay, Ms. Taylor, I'm going to move on. Mr. Gillihan?
Thank you, Madam President. So I'll try to be brief, but this is a topic that's near and dear to my heart. And first, I want to thank Kathy and the team for bringing a balanced discussion for us today. There's a couple points I want to make. First of all, it seems like this is a viable path, and it's working, but there are challenges that it sounds like they could be mitigated with plan design and other things. But I think what's getting lost in this conversation is that the folks that are moving in this direction in the private sector are moving in this direction in sort of an involuntary way. It's like, this is where we're going, this is what we're going to give you. For this board's benefit, I just wanted to establish for the record that this administration has advocated for a plan design like this for several years now, but we've never done it from the construct of it being involuntary or the only option. Our model was to add it to our existing plan designs, and we could do it with plan design changes that, by the way, would probably benefit our other plans as well. For example, it seems like to make this really work, we need better information on transparency, pricing, and health outcomes, and those sorts of things, which sounds like the entire industry is terrible at, based on some of the data we saw from Consumer Reports. So I would wonder what we're doing on that front anyhow, separate and apart from this, with our existing plans to improve that for our members. And I'm not going to ask for a response right now. I'm just sort of putting this on the record. And then for McKesson, it sounds like your satisfaction percentages are pretty high even after this transition. I wondered, do you have data on what it was before you started this transition?
Yeah, actually, prior to the high deductible health plan, well, we've always surveyed. As you can imagine, back when we had 81 plans, actually, believe it or not, it was high back then. They thought they had an amazing program. When we moved to what I'm going to call the consumer-driven approach back in 2010, it was the very beginning of our journey, we actually increased the plan value. Our goal was not to take away plan value. We increased it. But I think, and our scores dropped first year and stayed down for a number of years and have recently come back up. I think that the reason they dropped is just it was new and different and confusing and scary. And so.
Thank you. Ms. Hollinger?
Yeah, I just have a brief commentary. I'm probably the only one on this board who does have a high deductible plan with an HMO with Kaiser. And the commentary I wanted to make is on this belief that you have leverage. My son had to have emergency hernia surgery. My deductible, which I'm just getting, or my out-of-pocket, is over $5,000. Most of our stakeholders could not afford that. And not this concept that you have leverage, I think, is a misnomer, because you are captive. And so I would think that we're probably the people who go on this can afford it the least and really don't have my means to really scrutinize what you're paying for and whether or not it's accurate. So I think what you've done is kind of created a hybrid to eliminate some of that, those extraordinary expenses. I'm not sure if I think that's a true high deductible plan or not.
So
Thank
I
you.
have an anecdote. So one of my co-authors, he's a professor at Harvard and he has an MD. So one of the things he did was, because he was doing research with me on high deductible health plans, he enrolled in a high deductible health plan. He got a lot of flack from his wife that, you know, you're kind of mixing your research with our family life. And then he wrote a great blog about his daughter needing an eye procedure and how incredibly difficult it was for a Harvard professor with an MD to shop around and figure out how, you know, what's the best place to get.
Yeah, and I have a JD. That's my experience.
Thank you. Mr. Miller?
Yeah, thank you to all the panelists and staff for a very informative presentation. I'll try to keep this brief, which is always a challenge for me. From the perspective of representing members of CalPERS, employees, and as a union representative for many, many years, I really struggle with this idea of we're putting this out there as consumer choice. Expecting rationality or even reason from people on these kind of decisions, it's the same kind of thing when we push, let them make their own retirement investments. And so I know that these kind of designs, even with as much as you can do to try to mitigate the problems of these designs, it's a cost shift from the employer to the employees. There's also cost shift implied in our bigger world of collective bargaining that are adverse to the employees' interests. There are also, it seems to me, real issues of cost shift, generational shift, shift to people with more acuity or more need for services who are then stuck in either a plan that doesn't serve their needs or a plan that does but now costs much more. And given all that, I mean, it's a total non-starter for virtually anyone who is an exclusive representative of employees' interests. And so I'm curious, are you aware of any organization that exclusively represents the interests of employees, or retirees for that matter, who are supporters of these kind of high deductible plans, and what would their possible reasoning be?
I don't think anyone has an answer. Okay, thank you. Ms. Brown.
Thank you. I just want to bring us back to the initial comments when this conversation started, which is that I think I heard the doctor say that if we offer HDHPs, it actually causes an increase in cost in our other plans by about 5%, and ultimately could make our other plans unstable. So this is a non-starter for me. Thank you.
Thank you. Any other questions from the board? Oh, sorry, Mr. Fechner, please.
Thank you, Madam President. I just have a quick question. From those of you that have these plans, and those of you that have watched these plans, when they're offered, are they offered from the CEO all the way down to your lowest level employee at exactly the same rates?
So from McKesson's perspective, the plans are offered from the CEO all the way to the lowest paid employee, yes. What's different, where we differentiate, is in the salary banding that we do. So the CEO pays more for the same plan than a lower paid employee. So we have 4 salary bands. So the CEO pays more for his coverage as a starting point.
So it's like a per capita?
He pays, just based on his salary, he's in the top band, as are all our executives. Anybody over $110,000 a year pays the maximum amount for their health care coverage.
And actually, if you're a CEO, then these plans are more attractive to you because you're in a higher tax bracket. So when you put money in your health savings account, that leads to a higher saving. And if you're a CEO, you don't really care that much about the out-of-pocket costs. So in some sense, you're saving tax dollars. So if I were a CEO, I would enroll in a high deductible plan and have a huge amount of money in my health savings account to offset some of my taxes.
I would only disagree with you on the comment about the CEO not caring about the expense.
Well, we're already eating into our break, but I do have one question, unless board members have another. I don't see any other board members with a request to speak. And that is, Ms. Dubridge and Ms. Burrell, you both work for companies that have direct access on a daily basis to your members. For us, we are a purchaser on behalf of thousands of different employers across the state, spread out in a very fragmented fashion across the entire state. So we don't have the ability to have sort of on-the-ground services like you do, bringing in mammography or bringing in other kinds of screenings and biometric testing, et cetera, on site that you may have. The other thing that we have, and I didn't hear either of you address this, but perhaps you can answer the question, is we have retirees, early retirees, pre-Medicare retirees. And so we also have to access that population. And so can you extrapolate whether you think your experience would be relevant and can be translated for an organization such as ours, which can't have quite as high touch of an experience as you have in your plan. I guess that's really the base of my question.
You know, I would say there's a certain amount that you can extrapolate from what we've said, but really any employer is going to look at their population and probably design slightly differently. So Jerry's program isn't quite what Hewlett-Packard Enterprises is versus another employer. So I would say there are probably some lessons learned that would be helpful for you from our experiences, but I wouldn't say it would translate exactly, just like it wouldn't to another employer. And then in terms of thinking about, you know, your role as a purchaser, there's a component of what Jerry and I and our teams do that is purchasing as well, but we do have that direct access with our employees. But we have a very good understanding of the demographic of our employees too. So we understand the approach that we're taking in various parts of the country. We understand the jobs that people have, the pay that people have, and you know, average age and other risk factors, and we work very closely with our actuaries on what type of risk factors we're trying to build plans around. And so I would say those are the types of things that really are more important about driving what you would do across any of your designs than seeing something in the news or hearing one of us talk about something specific that we're doing.
Well, like you all, we've tried some of the consumer tools, and we've had very little uptake on them. They haven't really borne out. Members just are either don't think to use it, don't remember that it's available, don't find it useful. I don't know, but we've discontinued using them because they cost more than they were adding in value. All right, well, with that, this has been a very interesting panel. Thank you all very much for your contributions. We are now going to we do have a couple of members of the public who wish to speak. I'm going to call up J.J. Jelinczyk and then Donna Snodgrass. If you could identify yourself and your affiliation for the record, and you'll have 3 minutes to speak.
Thank you. I was closer, so I got here ahead of JJ. Donna Snodgrass, Health Benefits Director for Retired Public Employees Association. Just a couple of observations. Most of the board, I think you have already, you caught on to the same things that I did, but I just want to repeat it. Dr. Sood and Ms. Mendelsohn, thank you for your comments, because I think they most represent the CalPERS population and membership with the research. I'd also like to add that, Dr. Sood, your 80 to 90% high deductible health change that went into the health exchanges probably was because the law forced them to do that, and it's all they could afford. I do know several families who did that, and they still could not afford to go to the doctor, so they paid the premium and paid the price, as it were. HPE and McKesson appears to have a much smaller and more corralled population that they're working with. 70,000, I think I heard, employees versus 1.8 million in CalPERS. And there's fewer work sites to be visited to offer help and explanation with the plan features and give a more personal explanation. So it probably works better for you than it would be for the CalPERS members. And what would concern me most, and I think I heard it again from the board members, is that PERS, please consider the effect if you did something like this, which we would fight tooth and nail anyway, with the highest retiree populated plans, because healthy employed members are going to be migrating away from those plans, which could double the premiums for the retirees who are forced to stay in those plans. You're all aware of it, so I just wanted to go on record for our PEA that I support I see your faces. Thank you.
Thank you very much, Ms. Snodgrass. Mr. Jelinczyk.
J.J. Jelinczyk, speaking for myself. You've been talking about high deductible health plans, and words have meaning. And I will note that you have not been talking about high deductible health insurance. I tried to spike this discussion before I got on the board, while I was on the board. I didn't succeed in either case, so I don't expect to succeed off the board. But I do want to make a point to a couple of truisms. The trustees need to realize that they are trustees of a trust fund. No matter how they got there, no matter what other hats they wear, they have an obligation to the beneficiaries, not to the creator of the trust. The other thing that is very true about insurance, and it doesn't make any difference whether you're talking about health insurance, casualty insurance, life insurance, or even investment insurance products. The less coverage, the lower the premium. It works out that way for some strange reason. I understand that the employers really like this because they like lower wages, they like lower pension costs, they like lower health premiums. For the private sector employee, they have a slightly different motive than public sector employees. Private sector employees understand that if they have equipment, they need to maintain it, invest in it, fix it when it breaks. But if the equipment is people, they're expungible. And they have the advantage that they can take the cost of fixing their employees and pushing it off on the government, because ultimately the government is going to pick up those healthcare costs. Unfortunately, government doesn't have that option. They're going to pay for it one way or another, and so I would encourage you to do it as humanely and with as much dignity as possible. And I would also like to point out, as somebody pointed out, high deductible health plans don't make smarter people. So I tried to spike it before. I'd love to spike it again, but I really encourage you not to go down this road. Thank you.
Thank you. So that brings us to our break. It is 11 o'clock, so we'll break until 11:15.